Bela ma'am?
Yes.
Ma'am, actually, Dr. Ritu has got a patient and it's very critical. So she'll join in next 5 minutes. We'll start on time. But
Fine. That's
yes,
fine.
ma'am.
I'm here only. You can put a message in the chat box so that those who are viewers who join at 8:30 come to know that we are
Oh,
starting at 8:35. You can
yes.
just mention that.
No, we are starting at 8:30. She'll join 5 minutes after.
Okay.
Yeah.
Okay.
Ma'am, let's start. It's 8:30.
Okay. Then we'll wait for Dr. Ritu to join.
What, ma'am?
Dr. Ritu will then wait for Dr. Ritu to join.
Okay, you wanna wait?
No. Once we start the meeting, if she's
Yeah.
not there, then how
Yes,
we
she's joined here. She's here.
she's here?
Yeah,
Great.
just
Great.
enter. Yes.
Hi, Dr. Ritu. You are muted. Yes.
हाय बेला, वेलकम बेला। जब तक ना नम्रता स्टार्ट करेगी, मेरे पास एक पेशेंट ब्लीड हो रही है, मैं तुरंत अभी ज्वाइन हो जाऊंगी ओपीडी में, तुरंत हो जाऊंगी अभी। हाँ, सॉरी माय डियर, सॉरी। हाँ, तुरंत हो जाऊंगी मैं अभी। हाँ। नम्रता, लाइव नहीं जा रहा है बेटा अभी तक, लाइव स्टार्ट नहीं किया यूट्यूब पे, दिख नहीं रहा है मुझे।
नहीं, हो गया।
Just started.
Done. We are started.
अच्छा।
It's live.
हाँ, है। Done.
Let's start?
Yeah.
Yes.
मैं तुम रुको, तुम पहले खाली एक लाइन बोलना, मैं उसको वेलकम कर दूं, फिर तुम स्टार्ट करना। हाँ, एटलीस्ट वेलकम तो कर दूं मेरी दोस्त को यार। हाँ।
Good evening, everyone. I'm Namrita Madesh from MediSage E-Learning Private Limited, a leading platform dedicated to empowering medical professionals through knowledge sharing, expert insights, and digital innovation. And today, I welcome you all to yet an insightful Medtalk on Aneuploidy Screening. We are honored to have two distinguished speakers with us, Dr. Ritu Santwani and Dr. Bela Bhatt. Dr. Ritu Santwani, a highly respected obstetrician and gynecologist, infertility specialist, and sexologist. Dr. Santwani holds qualifications including MBBS, MD, FECOG, FIAOG, and ART Singapore. She is the founder and CEO of 360-Degree Healthcare Studio, NUHS Singapore, and is recognized among the top 50 influential doctors on social media. Joining her today with us is Dr. Bela Bhatt, MD, obstetrician and gynecologist, FECOG, lead consultant at Dr. Bela's Women's Hospital and Fetal Medicine Center, Mumbai. She is a renowned fetal medicine expert, FMF UK certified sonologist, and a FOXY certified trainer in obstetric ultrasound. Dr. Bhatt is also the chairperson of the FOXY Imaging Science Committee 2021 to 2024 and has authored the acclaimed book, The Vital Skill, Ultrasound in Obstetrics and Gynecology, a dynamic leader and multiple award winner. She is a vice president candidate for FOXY West Zone 2025 and a fierce advocate of women's health. Experts, we welcome you to the session. And now I request Dr. Ritu to take the session forward. Over to you, ma'am.
Thank you so much, Namrata, and thank you, Medtalk, for providing the platform for such academic initiatives. And big welcome to my dear friend, Dr. Bela. In spite of her very busy schedule, we are really thankful to the Bela that she has taken out the time for this academic initiative. So warm welcome to you, my dear Bela. I know Bela is very busy these days and a gem of the person, a good dancer, we can say a beauty with brain. She is always ready to help everyone. So friends, today what the topic we have chosen, the aneuploidy, as we all know, the Bela is the master blaster for this subject. So once we published this flyer, we received a lot of questions. Bela, see, I have shared you some questions also, what we have received via the groups only. So friends, I am stuck with one patient. Within a 2-3 minutes, I will join. Meanwhile, the Namrata will start the questions. Once again, warm welcome to you, dear Bela. Huh?
Yeah, thank you so much, dear Ritu. We are associated since so many years, dear, and it was my wish to be part of this wonderful webinar series, and it's my pleasure and honor to be part of this series of educational series webinar by Dr. Ritu Santwani. So thank you so much for making me part of it.
Yeah. Over to you, Namrata. Namrata?
Yes, ma'am, sure.
Yeah, please start taking the questions.
Yes. So, Dr. Bela, to begin with, could you please help us understand why aneuploidy screening has become such a critical aspect of modern prenatal care and what has changed in the recent years to bring it to the forefront?
Yeah, thank you so much. Number one, first of all, we know that since years in 1970s also we were doing screening for aneuploidy. Basically, aneuploidy is something we know that there are some common chromosomal problems which are seen in the general population, and we would like to screen like the Down syndrome, that is trisomy 21, 18, 13, which is one of three most common aneuploidies. Now, initially in 1970s, we didn't have good methods to try and screen patients for this. And the only test that we had was that for a high-risk patient more than 35 years, we used to do amniocentesis. And we had then one test to offer, that was triple marker. But again, the sensitivity of that triple marker was not very high. It was a second trimester test. So slowly, we were looking for better tests which are available early on in the pregnancy and with a better sensitivity. And after 1992, I would say, after Nicolet's threw light on the nuchal translucency, the first trimester nuchal scan, the entire world was sensitized towards doing it, the nuchal scan at 3rd month, and looking at the soft markers in the nuchal scan and trying to assess the risk for trisomy 21, 18, 13, and some of the common chromosomal problems. So yes, after that, we have addition of nuchal scan, then double marker, which are the first trimester screening test. Then we had quadruple marker, which is a better second trimester screening test. And of course, there was addition of NIPT in after 2010. And so since last 15 years, we have NIPT also in our armamentarium, which also has improved sensitivity for trying to assess the risk for these trisomies. So I think a lot of change has occurred in screening for aneuploidies in past 3 decades. Yeah. Yeah, I think Ritu is there, so she would like to continue. Ritu, you're muted. You're muted.
Yeah. Thank you so much, Bela. Yes, very nicely you have explained. Yes, we all know these days also lot of patients are also approaching to us. They once they search on the Google or they read somewhere about the aneuploidies, and then lot of questions are coming to us, especially with the infertility treated, or I can say with the IVF pregnancies. So a lot of patients will ask that is these testings are mandatory? This is a very important question. A lot of patients will ask us, Madam, that somewhere, somehow we have read somewhere that we have to go for the NIPT. So what do you think that for from
Yes.
your opinion, you please explain us.
So number one, we must understand that the common trisomies that we are talking about, trisomy 21, 18, 13, are affected by the age of mother. So initially we had only mother's age as the risk calculation for aneuploidy. So as I said, in 1970s, we used to take the cutoff, all the patients above 35 offer them amniocentesis rule out. But then we realized that by doing even amniocentesis beyond the age of 35, we were only able to pick up 30% of Down syndrome, and we were missing on 70% of Downs, because these 70% of Downs occur in the young population or younger mother, because there are more number of younger mothers than those mothers who are more than 35. So we were missing on that. So we realized that the screening for aneuploidy has to be universal. It has to be offered to each and every mother, because we know that the incidence of Down syndrome in general population is 1 in 800, right? Of
Correct.
course, 18 and 13 is slightly lesser, but Down syndrome is 1 in 800, and therefore it has to be offered to everyone. It's up to patient to decide whether they want to go for it or not, because there are some patients who say it's fine even if it is Down syndrome 18, 13, we are fine. We want to continue with the pregnancy. We're not going to do anything, and we don't want to undergo this screening process. That's a different issue altogether. Of course, you have to document that, but that's patient's choice. But it's our duty as obstetrician, as fetal medicine consultant, to offer this screening test for common aneuploidies.
Thank you. Thank you so much, Bela, for clarifying this. Bela, my next question to you. See, these days we are getting a lot of obese patients also. So this actually question was posted the flyer we have received from one of the doctor. So the doctor wants to clarify that is it this NIPT is having a correlation, or the results may vary in the patients with the maternal age and maternal body weight?
Yeah, sure. So that's a very good question, because for that we need to understand what is NIPT about. So in NIPT, what do we have? In that test, we have the cell-free DNA, right? We test on that. But those cell-free DNA, because we are drawing maternal blood, it will have both maternal fragments of DNA as well as the fetal fraction. So-called fetal fraction, because these are basically the apoptosis of syncytotrophoblast of placenta and the DNA fragments from the placental cells, which is there as representative of fetus. So we call it cell-free DNA of fetus and maternal. Now, what happens in obesity, that the amount of maternal fragments of DNA is so high that the chances of low fetal fraction becomes very high in NIPT. And we all know, for an NIPT to be reliable, we have to have fetal fraction of more than 4%. And when it is less than that, the chances of failure of the test or inconclusive test are very, very high, which we do not want. And that's the reason when it is obese patient, more so when the BMI is more than 35, 30, these are the patients whom we would not like to offer NIPT, because the chances of test failure are very high in these patients.
So friends, I think this point Dr. Bela has cleared very nicely. So yes, this is actually a very good question. A lot of doctors are having with this. There is one question I have received That is from Dr. Jadhav. He has joined all the way from Satara. So this question I've just received. See, this question I received in my WhatsApp. Doctor, is it any protocol, especially is it any protocol given by the Foxy also for the timing screenings of the what time screening? Actually, he has want to write something like that only. Yeah, is it any protocol given by the Foxy guidelines for the pregnancy screenings?
So pregnancy screening guidelines are there, but especially for aneuploidy screening, what we all follow is international what is followed, right? And for that, logic is more important. We all know that a screening test which has a higher sensitivity and is available early on in the pregnancy is the one which we all are going to offer, right? So the combined test, which is nuchal scan plus double marker, which is available at 3 months, that is at 11 to 13 weeks, 6 days, along with double marker, which is a good sensitivity, is the test that we would offer the patient first, right? So that's what we offer.
Okay. So being a better half of a medical legal consultant, so now there are a lot of doctors also having a lot of queries that what are the medical legal associations, which medical legal documents we need to have before having these procedures.
So we all know that when we do nuchal scan or genetic sonogram in second trimester, it's an ultrasound non-invasive test. So form F has to be filled. That we all know, in which section A, B, and D are to be filled. C is for invasive test. So that is to be kept blank. When we do any invasive procedures like amniocentesis or CVS, then again we fill up form F as well as form G. But in form F, in that for invasive procedure, we have to fill A, B, C, D, all 4 sections, because C is for invasive methods. So that's the difference between ultrasound and invasive methods.
Correct. Namrata, please take the next question. Namrata. Namrata?
Yeah, she's there.
Yeah.
So ma'am, one question that we have received is, hello doctor, how do you choose between NIPT, FTS and CVS in multifetal pregnancy?
Again, a good question. So multifetal gestation is something in which whether it's MCDA or DCDA pregnancy, number one, we can offer combined tests as long as both the fetuses are alive. That is one thing. The sensitivity is slightly lesser as compared to singleton. In singleton, it is 90 to 92%. In twins, you would find it around 85-87%. But then it is still good. Now, we come to NIPT. NIPT is a very good test for twins per se, because number one, we know that the false positive rate of NIPT is very low, less than 1%. When we compare the combined test versus NIPT in twins, combined test has a false positive rate of 5%. So what do I mean by false positive rate? These 5% patients are actually negative, but are falsely positive but labeled by combined test. So when they are labeled as high risk, falsely positive, we are going to offer invasive test to these patients, right? And in twins, I'll have to put in 2 needles to find out which one is affected. Fine. Same thing in NIPT. Now, NIPT, because it has a very low false positive rate, less than 1%, even if I put in 2 needles in falsely positive, the percentage is very low, less than 1%. So we are preventing putting 2 needles in many of the fetuses in which, on the basis of combined test, we would have put in needles. One thing. In twins, as such, the chances of abortion is high, slightly higher as compared to singleton pregnancy. And when we put in 2 needles, we are again increasing the risk of abortion. So, considering all this, a test which gives me lesser number of invasives will reduce the chances of abortion, and therefore NIPT is a good test to offer for aneuploidy screening in twins, and therefore ACOG also recommends that you can offer NIPT to all the patients. Again, one more thing I would like to emphasize here, that even if you offer NIPT, whether it's singleton, whether it's twins, nuchal scan has to be your primary screening test. You should not offer NIPT before doing nuchal scan, right? And there are reasons for that. Because on nuchal scan, we get a lot of other information. We look at the structural defects in the baby. We look at the nuchal translucency. Now, if my nuchal translucency is going to be more than 99 centile or more than 3.5 millimeter, then I'm not going to offer NIPT. I'll offer invasive. If there is any structural defect in the baby, I'll directly go for invasive. I'll not offer NIPT. So because there are contraindications of NIPT that we'll come to know in nuchal scan, the primary screening test, whether it's singleton or twins, has to be nuchal scan. After that, if there is no structure anomaly, if there are no major markers, then you can offer NIPT and discuss with the patient and offer the test.
Ma'am, our next question we have received is, what are the limitations of current aneuploidy screening methods in rural or resource limited settings?
Okay. So yes, rural areas, we know that 70% of India is in rural area where NIPT may not be available everywhere. So, but what I feel is, I think even in the most rural area of India, we have decent ultrasound machines which are available in every corner of India. And I think so nuchal scan is something at first trimester between 11 to 13 weeks, 6 days, which can be offered to all patients. So a good nuchal transfusion, nuchal scan done in a standard manner, and only even if you look at the nuchal translucency, that's also good enough in the rural area for aneuploidy screening. And you look at, of course, the basic structural defects in the baby. That's also the basic good enough screening for aneuploidies. But one condition here, whoever is doing it should always do it in a standard manner. We all know FMF UK offers online certification for nuchal scan. So it's the duty of the sonologist to learn it, to get it certified, because then you will have the software to calculate the risk for trisomy 21, 18, 13. And if you do it in a standard way, then only you are going to help the patient for risk calculation. So I think the basic nuchal scan is something everywhere. Even double marker to great extent is available in most of the rural areas. So combined test is something which can be universally offered with a good sensitivity. As I said, NT-NB and combined test also gives 90 to 92% sensitivity, which is good enough. You're muted. Namrata, you're muted.
Sorry, ma'am. The next question we received from our audience is, ma'am, what is your protocol for managing positive NIPT for trisomy 13 or 18 in asymptomatic mothers?
Mothers would not be symptomatic, first of all. These are all in fetal trisomy 18 and 13 that we are trying to find out. So NIPT, they are saying, okay. Now, NIPT is something in which if the 13, it is high risk for 13 or 18, I would first look at the structure of the fetus, which we would have looked at the nuchal scan. But there are chances that we will find some structural defect in the baby when there is trisomy 13 or 18. Now, if I look at the scan and if I do not find any structural defect or marker in the baby, and the NIPT is positive for 13 and 18, I would like to wait till 16 weeks. I'll have a relook at the baby if there is any structural defect, any marker which has appeared, and then offer amniocentesis. The reason being, in trisomy 13 and 18, the chances of a confined placental mosaicism at nuchal scan is slightly higher as compared to trisomy 21. And NIPT, as I said, is representative of the DNA which comes from the placenta. So if there is confined placental mosaicism, the fetus may be normal because I don't see any structural defect. But this NIPT is showing high risk. So it could be confined placental mosaicism. So if I wait till 16 weeks, have a relook, do amniocentesis, then I can pick up true trisomy 18-13 if at all they are there, and those who are false or because of placental mosaicism will be ruled out.
Ma'am, the next question we received is in twin pregnancies, how do you interpret an abnormal result when only one fetus is affected?
So NIPT shows high risk. And if I have some marker in one of the fetuses, I know that that fetus is more likely to be having that abnormality. Suppose this comes high risk for trisomy 21. And I know that nuchal fold, it's a DCDA twin pregnancy. And I know the nuchal translucency of twin A is high, more than 95th centile, but that of the twin B is normal. No other markers in twin B. So I know it's going to be twin A, which is at high risk. But again, when it comes to invasive testing, I will put a needle in both the fetuses because I want to prove that this one is affected. At the same time, I want to prove that the other one's karyotype is normal. So I have to put in double needle and try and find out which is affected, which is normal.
The next question is, how do you streamline decision making when NT is greater than 3.5 mm, but NIPT is negative?
Oh, very good question. Friends, when the NT is more than 3.5 mm, NIPT is not to be offered. A big no for NIPT. Why? Because when the nuchal translucency is more than 3.5 millimeters, see, remember one thing, NIPT is a very good test mainly for trisomy 21, 18, 13. Beyond that, the sensitivity is not good for other chromosomal problem, other genetic disorders. It will not pick up. Now, when the NT is more than 3.5 millimeter in the fetus, number one, I'll look at the structures, whether there is any cardiac anomaly, whether there is any mediastinal tumor which is causing high NT. I have ruled out structural defect. Then, chances of some genetic disorder in the baby are higher in this who have NT more than 3.5, in which case NIPT will show low risk. So we'll completely miss some genetic disorder which the baby is having because the NIPT is not able to pick up anything beyond 21, 18, 13 with a good sensitivity. So when there is the nuchal translucency is more than 3.5, directly offer CVS or amniocentesis, but a big no for NIPT because falsely NIPT will be low risk and you can still have some genetic disorder. So it's a contraindication for NIPT. Please do not offer NIPT when NT is more than 3.5.
Besides this, NIPT is a very costly test also. It is not very...
Yeah, that is true, but it is not good sensitivity. It doesn't pick up any other genetic disorder with good sensitivity.
Correct.
So you are wasting patients' money and giving false security to the patient when the baby is affected.
Correct.
Yeah.
So yes, we have received some more questions. Yeah, there is one very interesting question. Are there any lifestyle changes I can make it to reduce the risk of having a child with aneuploidy?
So basically, we know that these aneuploids are, especially trisomy 21, 18, 13, are mainly the risk increases with maternal age. The environmental factor do not affect it much because it's a genetic condition. But having said that, one lifestyle change that you can do is early marriage, early family planning at younger age, because of course that is going to reduce the number of chances of aneuploidy. And we all know that, taking care of obesity, stress, regular exercise and everything helps in overall health of you. And that would reduce the chances of obesity, diabetes and many fetal malformation and so many things in the pregnancy that would otherwise occur. Hypertension, PIH, diabetes, structural defects in the baby will all reduce. So that a healthier mother always is better for a healthier baby. That we all know for lifestyle changes.
Yeah, very true. So besides that, one more question. Yeah, this is also interesting question.
Ritu, I feel this is my viva going on. The live questions are coming and I'm giving a MD viva.
Now, can you tell us how much is the live? How many doctors?
No, that's fine. I'm okay with that. I'm enjoying. I'm just telling you.
Okay. Huh?
I'm enjoying. Tell me.
Okay, great. Huh? So there is one more question. That do you recommend aneuploidy screening in the cases with previously normal pregnancy outcomes?
Yes, why not? As I said, it's a universal screening. Every pregnancy, you have to offer the screening. It's not that only those who had past history of Down syndrome or something, they have high risk currents. No. Every mother, even young primey, I would give. So in second, third grade also, if there are previous normal babies, I would offer. It's a universal screening.
Correct, correct. So I think we have taken all the questions. Namrata, if any question you are able to see more, you can take. Otherwise, we are perfect on time. The show timing is half an hour.
Just, yes.
Yeah.
Yes, one more question we have received. I'm putting it in the chat box.
Yeah.
Ma'am, what role do fetal medicine specialists play in interpreting complex or conflicting screening results?
That will be challenging for obstetrician as well as fetal medicine consultant. Because see, that's the reason we keep insisting that if you have done a first trimester screening in a standard manner, that means it has been done in a standard way. It's duty of an obstetrician. Even if you are not doing nuchal scan on your own, it's your duty to have a look at the images which is done. A nuchal scan CRL should have been taken in a standard manner. The NT-NB image should be standard. And if you know that it has been done in a standard manner, the beta HCG PAPE have been done in a standard lab. And if you have done a combined screen, which you know with the sensitivity of 90 to 92%, with a false positive rate of 3 to 5%, then please do not offer the second trimester quad test, because that is where the patient gets confused, the obstetrician gets confused. You do first a screening test in first trimester, you do second screening test in second trimester, even in low risk patient, and then you have conflicting result, and then you are confused how to counsel, because once the thing goes in the mind of patient that this is high risk or whatever, then we have to offer diagnostic test. So to avoid that, remember, once you have done a first trimester screening in a standard manner, then we shouldn't offer the second trimester screening. Directly go for a good anomaly scan by a trained sonologist, because we always look at 9 markers of Down syndrome in the genetic sonogram that we always do with anomaly scan.
Yes. Now, these were the questions we received from our audience.
Yes.
So thank you, Bela. Thank you so much for taking out your precious time for our audience, and really grateful to you. I know you are very busy these days. You have taken out the time. So these programs are solely based on the knowledge sharing. So doing since the time period of the lockdown. So still the programs are very much appreciated by the doctors, though I'm not able to do in that frequency as I was doing earlier. But still आज भी डॉक्टर्स इस प्रोग्राम के लिए वेट करते हैं मेरे पास ऐसे मैसेजेस आते हैं
Heads off to you. Heads off to you. I must congratulate you for continuing this education series despite the COVID is over, because it's really helping so many people sitting at home. You know,
Yeah.
so it's entire credit goes to Dr. Ritu Santwani.
Thanks to the stalwarts also like you who have taken out the time and coming for the show, and thanks to this platform also, thanks to Medisage, thanks to beautiful Namrata and Diksha too, for always coordinating the program very beautifully. So with this, we will wind up, friends, for today. Over to you, Namrata, for the concluding remarks.
Thank you, Namrata from Medisage, and dear friend Dr. Ritu Santwani. Pleasure was all mine. Thank you.
Thank you.
Thank you, Dr. Bela and Dr. Ritu, for an insightful and clinical relevant session on aneuploidy screening. We deeply appreciate the time and expertise you've shared with Medisage community today and with everyone. And to our viewers, thank you for joining us, and we hope this Doc Talk has enriched your understanding and sparked important conversation around patient education. And don't forget to explore more such expert-led session on Medisage. So until next time, stay tuned, stay informed, and stay empowered. Thank you so much. Good night, everyone.
Thank you. Good night. Thank you. Thanks, dear.
Welcome, my dear. Bye-bye.
Recording is still on.